if they don't turn on, then batteries, which they have a bunch in there.
Oh, so these are different, because last time we had to, how do they mute them?
They just push the little button right here.
Oh. Huh. Oh, yeah, let's put them up towards the front. People never sit.
Here, that one works. Sometimes it takes a second. Okay.
Yeah, you too.
Would you prefer a lab or
Well, only.
Okay. Okay. It doesn't matter, whatever you want.
Oh, sure. Have a seat. I feel kind of funny having a mic too, but thanks for coming, everybody. We really appreciate it. My name's Miranda Meadow. I am the program manager at Civic, and I also participate on the Healthy Transitions Colorado Committee. So we have 3 speakers this morning, which I think will give us an excellent overview of kind of the issues of the role of medications in care transitions. And first up is Amy Panza. She is a pharmacist and co-owner of Tribus Transitions.
Hi, everybody. Thanks for having me this morning. I appreciate it. Basically, it's the first Monday after a holiday, so I know how busy today could be for all of you. So thank you for spending your time with me this morning. I am excited to be here to present and want to certainly thank Miranda and Civic and Healthy Transitions of Colorado. This is something that I'm very passionate about and would love to speak more about it. But in the essence that I only have 20 minutes, let's go ahead and get started. A little bit about myself. So as Miranda said, my name is Amy Panza. I have been a community pharmacist for a very long time. You can slide. I've been in some capacity in pharmacy since I was 16 years old. So I started in a pharmacy at 16, and I've basically been in the community ever since. So it's something that I pride myself on. I hope that I know what I'm talking about after these decades of experience. In 2015, I left traditional pharmacy community practice and started my own business called Medformation, and I consider it a visiting pharmacist service. So what does that mean? So that means I go into people's homes, okay? So I go into people's homes and basically talk to them about their medication therapies. So their supplements, their herbal meds, all that kind of stuff. And so, back up again? Yeah, that's okay. Stay here, there you go. Anyway, so some of the other services I provide in the home are disease state management. I do a lot of patient education, especially diabetes, cardiac issues, hypertension, mental illness, those kinds of things. I can also do pharmacogenomic testing, which is having a look inside somebody's genetics to see how well they metabolize medication. So I do also offer that service as well. And then I provide the client with an evaluation of what that report actually says, and if needed, their physician as well. This year, though, I started a company called Tribus Transitions, and we're going to talk about that a little bit more kind of at the end of my presentation. But basically what we've done is we've established a company that goes in to ensure smooth care transitions in between hospital and home, or hospital and rehab, or rehab home, depending on what the circumstances are. We're going to talk a little bit more about that at the end, but I want to talk a little bit about the 30-day readmission. So I think all of us here are familiar with the 30-day readmission rates and why we need to improve on them, right? So right now, obviously, 1 in 5 Medicare patients gets readmitted within 30 days. You know, you might say to yourself, well, I'm not on Medicare, so this doesn't really bother me. But the reality is that it should bother all of us. It's extraordinarily expensive. The estimates are $26 billion in taxpayer-funded money. So is what we're spending on having people get readmitted if they're on Medicare. And also, this is expensive for hospitals. So now that there's pay for performance models, hospitals are getting lower reimbursement rates if their patients are readmitted in 30 days. And so this is a very expensive thing that we all need to be concerned about. And certainly, some of you may have loved ones that have had to be readmitted within 30 days, and you have direct experience with this, right? So what I've come to find is that the discharge process in hospitals can vary. Some hospitals do a really great job right before discharge when they send folks home. But what I've come to find is that it's not usually a focus or priority. What the priority is turning over the bed, right? So we want to get another body in that bed, so we've got stuff we can bill for another client. And so when the discharge process in the hospital isn't solid, that there can really be some problems with that. So, and then certainly we've all experienced this, information transfer into the community can be very, very hard. Whether it's data hiccups, the transfer of information by a computer, or just the ability for a doctor to talk to another doctor in the community, et cetera. Go ahead. So there's something that I learned about recently that's not a real medical diagnosis, but it was something that I hadn't really given any thought to. And there's something called a post-discharge syndrome. And this is actually very, very common, and I've actually started to see it in my own practice now with Tribus transitions. But basically, when patients get home from the hospital, they are usually exhausted. They haven't slept well. There's beeping machines overnight, and people are coming in to draw labs, so they're exhausted. Oftentimes, they're malnourished, and they may have gotten food and nutrients in the hospital, but they haven't eaten nearly the way they usually eat in the community, correct? Some folks have cognitive decline, and that's especially apparent in our senior population. So they may actually come out of the hospital a little bit more declined than when they went in, and that's an important consideration. Certainly, they may have new medications, and that's very common. Otherwise, you wouldn't need to be hospitalized if we're not going to change anything about your care. And then obviously new disease processes. So how overwhelming is it for someone that they've been hospitalized with something potentially really catastrophic in their lives, and now they have to go home and deal with a new disease and new medications. So in 2008, the National Transition of Care Coalition made the following statement. They said patients and caregivers must take active responsibility for and become involved in their healthcare to ensure a seamless and safe transition of care. And I think that to play the devil's advocate is, what about healthcare literacy and patients' own level of activation, right? So this is a great expectation, but we all know that where there's wealth, there's health. And so what about all those folks who don't necessarily have enough education or enough literacy to understand what does it mean to navigate the healthcare system, right? So, and then also, how about activation? If any of you are clinicians in the room, we've all worked with patients who have said, I don't care, I'm not doing it. I'm not going to change my diet, I'm not going to take my meds, I'm not going to, and so what do we do with those particular patients? Next slide. So I took this slide, and I think everybody's seen this everywhere. I think it's on the Civic website. This is a really powerful slide to me because I think it demonstrates what is it that we're asking patients to navigate here, right? So when they're discharged, we're asking them to navigate all these different things. And I got to tell you, I've been in medicine for a long time. This makes me nervous. I haven't had to use a lot of healthcare, knock on wood, and thank God. But at some point, I may need to, and this actually makes me very nervous. And so if you can imagine those folks who don't have family support, they may not have community support, they may be underinsured or uninsured, this becomes actually a whole different monster. New slide. So I want to spend a little bit of time talking about meds and 30-day discharges. Obviously, I'm biased to anything medication related, right? But it's time that we start talking about medications in the discharge process, because I believe it's a huge, huge contributor in why patients are readmitted within 30 days. So one of the issues that I find is that oftentimes it's underreported, right? So I asked an emergency room physician once, I said, of the people that come back in to be readmitted within 30 days, how many of those people do you suspect are having a drug-related problem? And he said 50%. But now we don't code that as a reason for admission. We code it for disease process, we code it for something else, or hydration, or whatever the circumstances are. We don't code it for meds. And so it's grossly underreported. And the recent statistic that I found was 20 to 70% of patients have at least one med discrepancy at the time of discharge. Okay, so they've already been hospitalized. Now we're going to send them home, and there's already something wrong with the drug therapy. Okay, so for me as a pharmacist, it's extraordinarily concerning, right? And then there's all the other stuff that come with medications, right? I think people forget that medications are chemicals. You put it in your body, and something is going to happen, and it may not be pleasant. It may do what it's supposed to do, and it may not do anything. But we have to consider adverse drug events. We need to talk about any medication-related problems, and there can be a lot. Certainly cost and insurance issues. I've had patients throughout my career say, I can't afford this. I can't pick this up, I can't afford it. And so as a healthcare practitioner in the community, what do we do with that? How do we handle that, right? How about their ability to self-medicate? I recently worked with a Parkinson's patient who didn't have a lot of family available and who had a very, very hard time with trembling in his hands. So anytime he would pick up meds, he would drop some. So has anybody given that any thought? How do we make sure he gets his meds every day? And certainly level of cognition, right? Obviously there are some people who are home from the hospital and they may have some dementia or delirium type symptoms still residual. So we need to be conscious of that. And so some hospitals do a really good job of providing some medication education prior to discharge. They usually do. It's usually a pharmacy student, and we like students because they're free. So it's usually a pharmacy student. Sometimes it's a pharmacist on the floor, but they do go over some medication education before discharge. But I will tell you, given that post-discharge syndrome that we recently talked about, this education isn't enough, and we're going to talk about this a little bit further. Go ahead. So in thinking about medications, common culprits, there's, this list is by no means exhaustive, by no means. Obviously the first one is pain medications, and I was delighted to hear today that we're actually going to hear some more about how pain medications are so problematic in the discharge process. And in fact, I was just telling Felicia, one of our clients called me this weekend and said, my pain medicine isn't working. I am in excruciating pain. What do I need to do? Okay, and so she had the availability to me to call and say, what do I do? I'm afraid, I'm in pain. What do I do with my, what's the next step for me? So I was able to certainly intervene on that, but pain medications, right? So oftentimes in surgery, we do these sort of siloed order sets where if you're having a hip surgery, you get XYZ drugs upon discharge. If you're having a rotator cuff surgery, you get XYZ drugs on discharge. But I think the thing that medicine needs to be a little smarter about is those medications aren't necessarily the best for every person, right? And in fact, my own mother had an experience where her pain meds caused her delirium, and that required her to be re-hospitalized because she didn't know enough about her pain meds, just kept taking them, and became delirious. So, so the pain medications, we've got to talk more about that. And I'm not anti-pain meds by no means. I think pain meds are important, but they are common culprits, and we're obviously going to learn more about that today. Anticoagulants, especially warfarin, these can be very hard drugs to navigate with the blood draws and things like that. Now we've got some other more easy to use, user-friendly anticoagulants out there, but certainly there are still some folks who are on warfarin. Anti-diabetic medications are problematic. I've had people tell me that they have stopped their diabetic medication because their blood sugar normalized. Okay, well, yes, that's good, but you have to stay on the medication, right? And so those are certainly a problem. And not just the medication itself, but does the patient really understand diabetes? Do they understand what that means? Do they understand what they have to do in their own lives to try to manage that? And it's not just about meds, right? Antidepressants. So this is another one where people oftentimes will stop their meds because they feel better. Okay, well, that's all fine and dandy, but you got to stay on it. Any drugs which increase fall risk. Now, I could have had 15, if I had an hour with you guys, I'd have 15 slides on drugs that cause increase in fall risk. And sometimes they're drugs that people don't really think about. We think about pain meds and we think about antihypertensives, but you'd be surprised at the number of medicines that actually cause people to fall. And then certainly polypharmacy, right? So polypharmacy is, there's too many meds. So we send them home and they're on way too many meds, okay? Or they get home and they've got their old meds and some new meds. What do a lot of times people don't know, what do I do with my old meds? Am I still supposed to stay on those? What's changed? And that can be really confusing. Go ahead. So the recent focus has been on higher risk groups, right? So there's some CMS incentives out there for hospitals to really pay attention to folks in the following areas. So myocardial infarction, other cardiac events, pneumonia, heart failure, and those with recent hospitalizations, right? So right now, hospitals are watching these folks very carefully because they don't want them readmitted, because the hospital will have to pay a penalty for that, right? But, go ahead. I think the question that I have as a practitioner is, what about everybody else? Okay, so, and not to discount pneumonia and cardiac events and those with frequent readmission rates, but let's look at some others. And again, I could have had 100 slides on here. One of the ones that's really important to me is behavioral health. okay? The recidivism rate in behavioral health is extraordinarily high, okay? So who is it that's taking care of these folks once they get home? Are they set up with the community resources? Do they have transportation? Do they have everything they need? Do they have the right insurance? And is it going to cover the medication that that doctor put them on, which is always a very, very big concern. So behavioral health, what about surgery? Neurologic diseases, certainly, autoimmune diseases, diabetes, GI issues. So I kind of play the devil's advocate and say, well, yeah, we can focus on some high-risk groups, but what about everybody else? There's a lot of other people in the world, right? Next slide. So I want to talk a little bit about my business, Tribus Transitions. We are a health and care solution company. I'm going to talk to you a little bit about how we kind of all came together. Go ahead, Miranda. So there's 3 owners, and I'm representing today. One is on vacation. There's basically 3 of us, and we are all independent practitioners in our own way and have our own businesses. And I met both of these gals over the past couple of years with Medformation, and what we found was that we kept referring people to each other. Oh, you have somebody, I have somebody that you should work with, I have somebody that you should work with, yes. So we would refer patients back and forth, and we finally decided, why don't we just put our services together? Because ultimately that's what we're doing, is taking care of transitions of care. And so we combined, we all still have our individual businesses, but we've also combined now. So it's a little bit easier for patients, right? So they only have one HIPAA form to fill out, they only have one payment to make, they don't have to worry about all this other stuff, right? So it's myself, Kelly O'Connor, and she does Senior Care Authority. She is our elder care strategist and can help us with placement for any senior, anybody who needs placement outside the home. Mandy D'Ambrosia, she's the owner of Arrow Forward, and she's our medical advocate. And then, of course, there's myself, and I own Medformation, but I'm also the consulting pharmacist with Tribus Transition, so I handle all the medication reconciliation, information transfer to the community, et cetera, et cetera. So our main goal, the reason we decided to join forces, was we wanted to keep patients at home for careful recovery and in sound health. And anybody that works in discharge knows that that's actually a really lofty goal. Very, very hard. And of course, to reduce 30-day readmission rates, because when we reduce 30-day readmission rates, everybody wins. The taxpayers, the patient, the hospital, everybody wins, right? Next slide. So I come back to this. I come back to this slide a lot because it's so important and so valuable. And when people say, well, I still don't really understand enough about your services, what I tell people is we are the monkeys in the middle. And I mean that sincerely. We take care of all of this stuff. Right? So we are hired by patients so that we can help them navigate all of this. So we can keep them at home, we can hopefully let them have a safe recovery and not be readmitted. So that's kind of what we do, is we intervene in all of these areas to make sure that their care is appropriate post-discharge. Next slide. So we offer some other things. We do transition planning, so we sometimes work very closely with the discharge planners in the hospital before discharge. We've been known to go in and make sure we understand what the discharge plan is. We do care coordination. We help navigate healthcare. I obviously take care of the comprehensive medication evaluation. We do a lot of patient and caregiver education, and that's not only about medications, but the disease process, what's going on, why have you been hospitalized, how do we keep you out of the hospital. We do referral tracking and follow-up. We provide all the information to community providers, and we can certainly do things like legal and financial needs overviews for families as well, because oftentimes those things come up in crisis, and we can certainly help with that. Next slide. So for more information about either my company, Medformation, you can visit my website. You can email me at amy@medformationllc.com, or certainly Tribus Transitions has its own website. You can go there. And obviously you can email me at tribustransitions.com. I have a lot of emails to check, but I'm very good on email, so feel free to email me if you have any other questions or concerns. But I'd love to take some questions from any of you. Yes?
You said patients hire you?
Yes.
So are you cash fee for service?
We are fee for service. The goal is not to stay fee for service. We believe very strongly that all patients should receive a level of care like ours. And that's a lofty goal, right? Insurers want to see a lot of numbers. And right now, as a fee for service model, we are capturing the numbers, but it's a lot slower. we are trying to partner with rehab centers, insurers, things like that, to try to get a more steady stream of patients so that we can capture the data a little bit faster. And that way we can go to insurers and say, this is something that you really should cover for folks, because here's why, here's the data to support it. Other questions? Yes, ma'am.
So how long have you been doing this?
So Tribus Transitions just opened their doors in April. A med formation I've had since 2015, so a couple of years now.
So when you opened for business and till now, and maybe you can't tell me this, but how are your patients doing that you are keeping track of? Are you finding that you're getting a pretty over 50% success rate in going into the home and?
So thank you for that question. She wants to know what our success rate is, basically. So far, it's 100% reducing 30-day readmissions, and we may want to start looking at 60-day readmissions because some of our patients can be very complicated. And so we're starting to think about 60-day readmissions and working with families on, we may need to go another 30 days because of some of the complexities post-discharge, or if there's been some worsening of the disease process or some of those other things. But so far, we're 100%. So, yeah, so we're pretty happy about that. Other questions? Yes.
Have you had any experience working with behavioral health patients and readmissions?
So I have, actually, personally. I used to be a director at a Highlands Behavioral Health. I was the director of pharmacy there. I've also done some interim director work at other psychiatric facilities around town. And obviously in my years of community practice, I saw really firsthand what patients come, when somebody comes in for behavioral health meds, I've really seen firsthand what the challenges are. Oftentimes they might be discharged after receiving a shot, and so they need to come in and get another long-acting shot, and their insurance doesn't cover it, right? And that's a very common thing. Or we've switched their antidepressant in-house. We send them back to the community, and again, there's an insurance hiccup, or there's some confusion about that. A lot of patients don't have really great community support or family support, unfortunately, and so there's, how do we intervene in those areas? But no, certainly behavioral health is a unique challenge, but I don't think it's one that we couldn't handle. Yes?
Do you deal with a lot of patients when they leave the hospital, need to get back to the doctor's office for whatever reasons, checkups or whatever? There's transportation issues, and getting patients to and from doctor's offices that may not have the transportation.
So I don't know if everybody heard her, but there's a transportation issue in the community, and the reality of that is 100% true. In fact, our most recent client, number one, she didn't want to stop driving. That's something that seniors hold on to very strongly because it's a sense of identity and freedom. But because driving caused too much pain, she didn't know what options she had. And even riding in a car is painful. Whether she's driving or not, riding in a car was very painful considering what she was going through. So we did have to look into some transportation resources. Now, thankfully, this particular patient has some means and also has some family nearby. So it wasn't that complicated to work into. But there are a lot of things now that people don't know that exist. There's Uber. And I believe that Uber now is working, or it might be Lyft, that's doing some work with the community in regarding healthcare. And I don't know if they're discounted rates or they're working side by side with hospitals. I haven't looked into that yet. But there are so many more transportation options available to everybody now, and part of our job is to educate around that, right? So this particular patient that we have, 70-some years old, she's just always driven. So, I live in the city, so I'm aware of some of those more hip, urban things. Oh, let's take an Uber, let's take a Lyft. But those services do exist for everybody else, even outside the city. And so that is something that we've had to address with patients, absolutely. And I do believe for some Medicaid patients, and correct me if I'm wrong, or maybe even Medicare, there is some transportation coverage, there's Access-a-Ride, and there's some other things. But certainly if you're on commercial insurance, or don't have insurance, those options are not available to you. Yes?
Question on the 30-day readmission policy.
Yes.
I guess I'm a little bit concerned that if you have 100%, isn't it possible that some people would legitimately have something that couldn't be foreseen?
Oh, absolutely.
I'm just thinking
Absolutely.
of someone, with a heart surgery.
Oh, absolutely.
And then 2 weeks later, they have AFib or something.
Well, that's right.
They shouldn't have been kept in the hospital for 2 weeks just in case.
Well, that's
but
right.
They really do need to go
That's
back.
right. No, and that's something that's part of the data collection that we're having to tweak out, is going to be either disease progression that was unavoidable or the presence of another disease that's caused the readmission. So it's about sort of tweaking the data and making sure that they're not being readmitted for the same issue that they were admitted for. So yeah, so there's a consideration.
So your staff have taken that out. So if there was an unrelated something.
Exactly.
That did send them back in 30 days.
Exactly.
Okay.
Right. You know, it's no different if I got home, maybe I have diabetes, I just get home, and then I go take a bike ride and I get hit by a car. Well, Tribus Transitions couldn't help you with that, right? I mean, we tell you to put on your helmet, do all those things, but so we are keeping that data separate, for sure. And there will be things that we can't prevent, unfortunately, although we really try.
Well, it could have been related, you know,
Absolutely.
like an infection that came up after
That's right.
that surgery a week or two later. I mean,
Well, and that's
it's related, but it's not.
And that's exactly why we're starting to look at 60-day readmit data too, because one of our current clients is very complicated, and I think that that could happen, that there could be, no matter how much we intervene in the community, that there could be that one thing that we just can't, you know, our body's going to do something, and it's going to go this way or that way, and none of us can really affect that in spite of what we're doing. So, yeah. Thank you. Any other questions? Okay. Well, I appreciate everybody's time. Thank you very much, and I'll hand it over.
Thank you so much, Amy. All right, and now we have Dr. Rick May, who is the Chief Medical Officer for RxAssurance.
Let's see, do we actually need this? For the recording? Okay, we'll do that. All right. Well, first of all, thank you guys for coming out today. My name is Rick May. I'm an orthopedic surgeon by training. I'm actually an orthopedic trauma surgeon, was my specialty for many years. I also like to describe myself essentially as a recovering opioid overprescriber. So those of you who worked in hospitals and have seen these ridiculous scripts that doctors used to write sometimes, you guys are nodding, you probably have seen those. Never seen them. Anyway, but I think, I'm sure you've seen them. I was one of the guys that wrote those ridiculous scripts because back in the day when I was trained, we thought, well, if a little bit of opioid is good, then a whole bunch more opioids is probably better. So rather than giving them 20 and last a week, let's give them 100, and that way they're covered for the next month. And that way they don't have to call in on the weekends and bug me anyway. So anyway, that was kind of our habit for a long time. And a lot of times, frankly, we worry, say, well, maybe the Percocet's too powerful, so let's give them Percocet and Vicodin both, and that way they can choose whichever one they want. Well, the challenge has been over time, and you can advance that, please. Many more physicians than just me have followed similar patterns. And the result of the last 20 years have been pretty catastrophic in terms of America right now. If you look back at the US, everything essentially, the number, remember, is essentially quadrupled. So the amount of opioid use has quadrupled in the US, the amount of misuse has quadrupled, the amount of overdoses has quadrupled, the amount of opioid-related deaths has quadrupled, the amount of people addicted to opioids has quadrupled, and the amount of people that have started on opioids and transitioned over to heroin is about 8 times higher. So every single thing you can imagine bad happening with opioids has happened extremely horribly over the last several years. And we could spend a lot of time talking about the marketing and everything else that went into the opioids sort of exploding. But the bottom line is this: again, we've seen a 400% increase in deaths, and now opioid deaths are really higher than motor vehicle deaths, than firearm deaths. And it's really interesting in terms of just the overall impact on health across the country. I'm sure everybody's heard about the opioid problems. Next slide, please. One thing interesting in Colorado is Colorado has not been spared in any way by this. Basically, look at Colorado. Every single day in Colorado, we have 25 to 30 people that overdose here in Colorado. 2 or 3 people die here in Colorado. Again, the numbers are reflective of Colorado. This is basically the number of deaths in Colorado. The red line is kind of the one to keep track of. That's our opioid-related, basically, deaths over the last 10 years or so. So you can see it's a bad number. Click it one more time for me. And one challenge is it's important to recognize that it's not limited to any particular part of Colorado. In fact, out of the 63 counties in Colorado, 64 counties have seen increasing death rates over the last 12 years. So it's a widespread problem across the nation. It certainly is here in Colorado, and it affects essentially every single county in the state. Also, I think it's important to recognize is for every one you hear about the deaths, you hear about people showing in the emergency room, there are hundreds, even thousands of other patients below that end up having to be admitted for abuse, come into the emergency room because of opioid problems, Basically, there are 115 or so for everyone that dies that are dependent, and there are basically 733 what they call the non-medical users. So people that are basically taking the prescriptions that they shouldn't be taking, or taking them too much, or mixing with other types of things. So it's a widespread problem. Next slide, please. Let's talk a little bit about specific to care transitions. And care transitions are a very interesting point in time. And I think it's actually a huge opportunity if we take advantage of it the right way. Now, obviously we talk about medications in general and they have to be managed in terms of discharge. It's important to recognize that opioids are a very important, very sort of different class of meds. There's a couple of big challenges around opioids. Number one is, which is one thing I want to emphasize, is the first thing is opioids are actually not very good for most types of pain. And I'll say that again because I want to be real clear about it. Opioids are actually not very good pain medicines. In fact, if you look at most studies for most types of pain, I'm not talking about really bad things like chronic cancer pain and things, but for the vast majority of pain you see in the hospital, post-surgical pain, the stuff that I saw a lot, things like fractures and broken bones, most patients, if they don't know what they're getting, will actually get better relief from a combination of Tylenol and Motrin than they will from opioids. In fact, most of them get vastly better relief. Now, the challenge has been that over the years, we've gotten into the habit of prescribing opioids for almost anything. You go to a doctor with headaches, and they'll give you opioids. You go in with back pain, they'll give you opioids. You have a sprained ankle, they'll give you opioids. One of the scary trends we've also seen is that in kids, kids that have like some wisdom teeth taken out or they have a small strain, they're getting opioids. And that's a profoundly, profoundly disturbing problem because young people's brains are especially susceptible to all the bad things that opioids do chemically to our brains. So as a country, we've gotten this habit of vastly overprescribing. Now, one of the challenges I like to emphasize is this. So in my training, again, I was an orthopedic trauma surgeon. Ortho is a big area where a lot of people use a lot of medications. In my entire 9 years of training, 4 years of medical school, 5 years residency, I had 2 days as a second-year medical student where I learned about the pharmacology of opioids. In other words, why they work and how they work. That's it. I never got any other formalized education about opioids ever again the rest of my training. In fact, what I most learned about opioids was I was an intern my second day, and we had to discharge a patient after a knee replacement. And I asked my chief resident, I said, well, what do I do? They said, just give them 50 or whatever they want and send them out the door. And that was about as much as we learned. And right now in America, it's important to recognize that 95% of physicians' experience is exactly the same as mine. We have not been trained on opioids. And if you think about it, it's kind of weird because the vast majority of doctors at some point in their career prescribe opioids. But they really don't know how to use them. They don't know how to assess patients for risk of opioids. We don't know really what opioids are best. We don't know how to monitor them correctly. If you think about it, if you're a doc that does diabetic management, most of those docs know everything about the diabetic meds. They know the pharmacology, they know the dosing, they know the side effects. They have vast, vast information. Antihypertensive drugs, things like antibiotics. The docs that use those are incredibly well versed on those. But for the most part, nobody knows anything about opioids. And I want to emphasize that because when it comes to the care transition point, this is a great opportunity for everyone involved in that process to think about what is happening with the opioids, and potentially challenge what's going to happen automatically. Because Amy alluded to, a lot of the order sets are just like, discharge the patient to home and here are the meds they get, regardless of what the risk factors are, regardless of their other medications, regardless if the medications are even going to be effective for them. They'll just get the standard stock meds everybody sends out. It's an opportunity to challenge and say, hey, listen, maybe we should stop and think about doing something else. Some other things important to recognize about opioids. I mentioned they're not very good for pain, but also there's all these things we know about them in terms of the fact that they cause hallucinations, they cause bowel problems, they cause nausea, they cause depression, and too much that can make you stop breathing, things like that. But there's also some new things that are coming up which are very interesting. One is interesting immune system suppression, which I didn't know about before. But opioids, depending on the doses, can actually make you more susceptible to infection. So if you just had a surgery, for example, in the hospital, the opioids can make you at higher risk for infections. What also is interesting is this process called hyperalgesia. I'm sure I talked about it a lot in the pharmacy world. Hyperalgesia basically means, and I won't have time to talk about the details of it, but basically it means that the nerves that essentially normally get suppressed by the opioids now get turned on. So rather than turning down the volume knob on your pain sensors, the opioids themselves crank up the volume knob on your pain sensors, and the opioids now start to make the people's pain worse and worse. And you imagine if pain gets worse, what do? They take more opioids, exactly, and the problem gets worse and worse over time. So there's all these issues we're seeing. The other thing too, which is interesting, is even brief exposure to opioids actually has been shown to decrease gray matter in your brain. So even small exposures basically make you dumber. So it's all these bad problems. Next slide, please. One thing that's fascinating to me was this recent study came out. This is in JAMA. Many of you know JAMA is kind of like the best research article in the world, best reference source in the world. They looked at 36,000 patients, not a small study, and all of these patients were in having pretty simple surgeries. We're talking about elective surgeries, ambulatory surgeries, so things like a knee arthroscopy or carpal tunnel release, things like that, so relatively small. They also took a group of patients, 36,000 patients, that had not been on opioids before. These are not folks in chronic pain for their rotator cuff, shoulder, or whatever else. And then they looked at them over the next several months after they got discharged. And it turns out that about 6% of them stayed on opioids at least 90 days. Now, for those of you that have worked in the opioid world, one thing that's important to recognize is 90 days is kind of like the cliff. It's like the precipice. As it turns out, if we keep people on opioids more than 90 days, the majority of them will never come off again. They will become lifetime users of opioids. That happens for a lot of different reasons, and almost none of them are related to the fact that they have pain. It's almost always related to the fact that once they get a taste for it, once your brain gets a taste of what the opioids do, you get hooked on it forever. Let's talk about the fact that opioids actually have an interesting, almost like they have their own self-marketing program. Basically, they go into your head, they change the way that your brain responds chemically to the opioids, and it makes you want the opioids more and more and more. And that's the problem. Once people are on it for 90 days, they never come off again. So what this means overall is, by the estimation of this study, there are probably about 2 million people that we take every year in the United States who come in for some minor surgery. As they're going out the door, we give them a handful of opioids and say, here, go enjoy these. And they never come back again. They become now long-term opioid dependent for the rest of their lives. And if you include in that, again, this is just ambulatory, elective, small stuff. If you include the bigger surgeries, the knee replacements, hip replacements, the spines, all those types of big procedures we do, the numbers are probably vastly bigger than this. Next, please. There's some things to think about in care transition time. As I mentioned, this is an important time to really stop and think, okay, do we really need these opioids? And I really encourage anybody that's involved in this process, challenge your prescribers, challenge your doctors, challenge your nurse practitioners, who's ever prescribing these meds. If you have standing orders, as Amy mentioned, that automatically give patients opioids, challenge that, because I can guarantee you the doctors, for the most part, don't know the damage they're doing. All the physicians assume their prescribing is okay, so it's okay to push back on the doctors and say that we really need to send this person out with 50 Percocet after a knee scope. We don't. So think about those types of things. Talk with the patients and their families about opioids. Help them understand that these are very dangerous drugs. Mention the fact that it's a very, very high risk of getting hooked on them long term. Mention the fact that even if they need them for short periods, it's important to get rid of them as soon as they possibly can. Consider, if you have, especially standing orders, limit the amount of opioids you send people out with. Again, the vast majority of patients I dealt with, and I did a lot of, again, trauma stuff and everything else, the vast majority of people with those types of injuries really don't need opioids more than a few days. I'm talking like 2 or 3 at the most, and some not at all. The other thing is, if longer use is necessary as part of the discharge process, obviously we want to look at the opioids, make sure we're getting the right dosages, but think about some other things. There's a tool out there called the ORT, which is the opioid risk tool, which actually can assess patients' risk for longer term problems. So if patients are going to have to get pretty big doses of opioids on the way out, we can actually use that test to basically understand, how high risk they are. Think about long-acting meds. Long-acting meds have lower abuse potential. And then the last thing is naloxone. For those of you who don't know, anybody know what naloxone is? We're familiar with it, so, okay. Basically, I was making this part about naloxone too. Naloxone is essentially what they call a perfect antidote. All right, naloxone is a remarkable reversal agent. You can give it, and it will basically very quickly turn off the entire effects of opioids. So folks that are, for example, dying because they're not breathing, you can give it to them, and within seconds it reverses it. You may usually one dose, but sometimes multiple doses. Turns it off. If you give it to someone who's not overdosing, it doesn't do anything to them at all. There's no downside to it pretty much at all. So naloxone as a reversal agent is basically a perfect antidote. So we talk about it a lot. If patients are going to have to go out on long-term opioids, get them a naloxone prescription. I'm not sure if you guys know this. Actually, right now, any person in Colorado can walk into any pharmacy and get naloxone now without a prescription. So it's available at any pharmacy out there. Next, please. Thanks. A couple of things. With med reconciliation, obviously a big issue within hospitals. Everybody seems like they struggle with it. Make an extra point to do an extra good job with opioid med reconciliation. Talk about the patients and their families about the meds themselves, but also how to store it And last thing is also how to get rid of it. The biggest source of opioids that people end up using illicitly is not actually buying from some drug deal on the street. It's from getting it from friends or family. Oftentimes the nephews come over to their aunt's house and they go through the medicine cabinet while they're going to the bathroom and they find the old Vicodin prescription and they take it with them. So it's important to recognize that once the meds are used, get rid of them appropriately. Tell the patient obviously to avoid mixing the opioids with anything else, avoid any alcohol, avoid any types of what we call CNS, central nervous system depressants, so that's going to sort of bring them down. One critical thing I want to make a point of is benzodiazepines. So benzodiazepines are all the sort of relaxant stuff, so the Valiums and the Ativans of the world. It's now part of the big national guidelines that say basically at this point opioids should never be used simultaneously with benzodiazepines. If you look at the risk of overdose, people that are simultaneously on opioids and benzodiazepines are 10 times higher, more likely to overdose than patients who are just on opioids themselves. So if there's nothing else you do is to look at the list. If patients have to go out with opioids, see if you can stop their benzodiazepines. Identify the provider who's going to be responsible for refilling the meds, because oftentimes the patients go out and they'll see the orthopedic surgeon and they'll refill their meds, and they do primary care and they'll refill the meds and somebody else may refill it. And the last thing is really talk about with the patient and the family about how to taper off the meds over time. What's going to be the plan to stop it? How soon can they get off of it? Let them know, again, these are very, very risky medications, and the sooner we can stop them, the safer their family member is going to be. All right, next please. I do always like to finish with this one slide, which I think is important. It's a little bit complicated, but I'll walk you through it. This slide outlines basically where people who are abusing opioids, where they get their medications. Now, seriously, if you look at this green and blue section together, that's basically people who get them from family or friends. Either they're buying them from, or most of them are actually giving them, or they're finding them in their aunt's medicine cabinet. Right? Smaller sliver of this over here is the doctors. Okay, they're getting legitimate prescription from the doctor's piece over here. The actual illicit piece from dealers and that kind of stuff is very small. It's less than 10%. What's important to recognize, though, is even among the people that get it from relatives and friends, 85% of that is actually coming from a prescription from a physician. What this all boils down to is, besides about less than 10% of what's out there abused, 90+% of all the opioids that get abused out there in our society initially come from a legitimate prescription from a physician or other provider. So we are the source. We are the faucet on this fire hose that's blowing out in the community. So again, every opportunity we have to look at that in terms of physicians' offices, in terms of transitions out of the hospital, any point in that process we can take a look at opioids and try and say no to them, diminish them, cut them off quicker, have them be managed more effectively. All of those things help to stop this problem. Because again, right now, people talk about, well, it's a huge problem with drug abuse out there, and there's all this illicit fentanyl and everything else coming in from outside the country, which is true. But again, some of the problem, it really comes from healthcare providers in our system, which are producing thousands and millions of addicts every year in the United States. So it's up to us to stop. I think I'm almost out of time here, but let me pause for a second. Any questions about stuff? Yes, sir.
Have you found chronic pain management programs that don't use opioids that are effective?
It's actually a fascinating idea. Almost all chronic pain programs, well, a couple of things. One is there aren't enough of them. We have a real shortage in Colorado, but also around the country. There just aren't enough chronic pain specialists out there. Almost all of them are still very focused on medications, which is very interesting, again, because there are so many other modalities which are out, in many cases, are much, much more effective than medications in managing people's pain. But almost all the ones we see out there now, or at least initially, are focused on medication management. Yes.
So how do you feel about if you had a patient who came in and had a procedure done, the knee replacement, and they were out 10-day surgery, and you sent them home with a 7-day supply of opioids? I mean, is that, to me, I feel that there's pushback on that, but I feel like there's some docs who agree with it, and I don't know if it's changing, or how do you feel about that?
Do you understand the question about, like, what happens if you limit basically a 7-day supply? Well, it's a couple of challenges. One is, what's a 7-day supply of opioids?
I guess it depends upon the drug and how many times the package says you have to take it because it's half-life.
Right, but so a couple of things. So I can write for the package recommendation. I can also write off-label. So as a physician, I have wide basically control over whatever I want to write for. So one of the challenges with like specific 7-day limits, for example, is the fact that I can write virtually anything I need to get around a 7-day limit. In other words, I can take 3 weeks worth of drugs and smash them into 7 days if I write them the right way. So that's one of the challenges. It's hard to say 7 days is going to limit it enough. I think it's the right idea to start getting the docs thinking about it, but certainly there's ways to get around it. What's interesting though is, just a small aside, is for example, there's a guy in Arkansas right now, super smart guy, his name is Lowry Barnes. He's an orthopedic surgeon who does essentially same-day knee replacements. Usually keep them overnight, but within 24 hours. They use a combination of injectable anesthetics around the knee, with basically afterwards Tylenol and Advil essentially to go out with, and they get essentially 100% pain control without use of narcotics at all for the vast majority of their patients. So what it comes down to is things like 7-day limits. I think it's a good thing to think about and talk about. The challenge is the fact that docs have ways to get around it. What I think we need to see more of is people actually looking and saying, you know what, let's start challenging some of these fundamental assumptions like, oh, after a knee replacement, everybody's got to have big pain meds. As it turns out, you probably don't. There's lots of ways around it. We just haven't actually ever looked at it in kind of detail we need to. The other thing too, just to be frankly honest and a little bit crass, is right now the docs don't get paid enough to care about it. A patient comes in and some of the more, for example, non-pharmacologic ways to deal with pain takes a lot of time, a lot of conversation, that kind of stuff. I don't get paid for that at all. I can write a Percocet prescription for 50 pills in less than 60 seconds and walk out the door. The patient will be happy. They think I'm taking care of them the right way. I can get on to my next patient and go from there. And our system is really not geared to make more of these kind of rational, sort of thought out decisions about things.
Dr. Ramsey, and one of the things I just want to say too is you may, in all intents and purposes, give somebody a 7-day supply of pain meds, but they may not take it as prescribed. And that certainly is epidemic. Or you get sort of a, range order, take 1 or 2 tablets. People are taking 2 tablets, and really maybe only one would have been fine. And there's no education around, so there's a lot of things that go into it.
Or we can you say, okay, a 7-day limit, great. So I'll write them for Percocet for 7 days and Vicodin for 7 days and something else for 7 days. So now I have a 7-day limit, but I've given them basically a month's worth of medications. So.
But what about the drug-drug interaction?
You mean the fact that you can kill them with all 3 taken together? Yeah, that's a bad thing. But again, that's part of the problem. We sort of laugh about it, but I mean, it's really true. It's hard to overemphasize this. The prescribers in this country, in general, do not know what they're doing with opioids. And it's a fundamental flaw in the system. And we have lots of online CME, and there's lots of recommendations out there, and I can guarantee in talking to docs, the vast majority of docs do not know anything about the current recommendations on how to prescribe opioids.
What would you like to see change about that? Like, should this be a continuing education requirement, put upon doctors, or, we can't go back and read, once you're practicing, most doctors aren't going to go back and re-educate on it, but how do we then ensure that if they don't have time to look up the current recommendations, some of the great things happening in other states and what people are doing, how do we ensure that prescribers I don't know, that they understand all of it, I guess. Do you have an opinion?
They're not killing people on a regular basis, yeah. Well, a couple of things. So you can try and require CME. The challenge with docs is they're pretty clever. They'll do the CME, they'll pass it, they'll get an A on it, and they'll completely forget about it the next day. And I don't want to be crass about docs. Again, doctors in general are very smart people, incredibly hardworking, remarkably honest, smart, very, very solid people. The challenge is they are vastly, vastly overtaxed right now. They are stressed to the limit. They are running every second of every day. They can barely keep up with the basic stuff they have to keep up on. So you throw something else in the mix, they push back and say, okay, well, if you require me to do, I'll check off the list and I'll do whatever you say, but I'll keep doing what I do. So I think the real answer lies in 2 things. One is that right now we need to change medical education to require it. That's happening now, unfortunately. Most of the medical schools and residency programs are now including mandatory opioid education. The other thing too, though, is it's like anything else. It's mentioned with like the drug-drug interactions. Is it's important to recognize that when you have 5 physicians working on a patient, all of who have disconnected EHR systems, everybody's prescribing different things. A lot of times the doctors don't know what the different medications are. So we have to look for systematic changes to be able to say, let's put into the system alerts and things like that to let the doctors know, by the way, Dr. Jones, you want to write for this patient for benzodiazepine, they're also getting big doses of opioids from somebody else, or vice versa. So I think you have to look at system changes to make it easier to understand for the docs to kind of, be told, by the way, there's a problem with this, there's an issue with this patient, those types of things. Because I think most doctors really do have a really intense interest about doing highest possible quality for their patients. Just right now, again, if you say, I got something to do for your patients, only going to take 1 more minute per patient per day, they won't do it because they haven't got the time, which sounds horrible in some ways, but just trying to be realistic about where the docs are. They're really struggling. Yes.
Do you think there'd be some value in patient education and to use opioids as the last resort? Educate the patient in terms of what, like you talked about today, how it changes the brain, and it really should be last resort.
That's a fantastic suggestion. That's what I'd love to see, actually, is a kind of a nationwide, a lot of money invested in a very cool, slick advertising campaign, sort of all different media sources you can imagine, social media and television, everything else, really explaining some of the basic stuff. These meds are not very good for pain overall, despite what you've been told. They are horrible for your brain and your body. They're vastly more addictive than you could possibly imagine. Your doctors don't always understand what you're taking and that sort of things. So basically help yourself, defend yourself, stop, the problem from developing for you and your family.
Yeah, because a lot of times I think patients go in and doctors just feel like they've tried so many different things and they just want to help that patient, and they'll just give them a prescription just to make them feel like they're helping them.
Yeah. And I did the math on this a few months ago. I almost cringe when I say this. In my career, I have prescribed well over 1 million opioid pills, 1 million opioid pills. I never gave out a single one of those without thinking it was in the best interest of the patients. I always did it for the right reasons. I just probably shouldn't have done the vast majority.
I'm having a little disconnect with one of the statements that you've made. I was told that heroin is actually a really powerful painkiller, one of the most powerful painkillers known to man. I was told that, but it's not used, it's illegal, and it's highly addictive, and morphine is basically the same thing, just not as concentrated, and so we use that instead. But now, and you're saying that it's not a good painkiller. Can you just maybe connect those two? I mean, why have we been told that?
Well, here's the challenge. Opioids work through a certain mechanism in the brain. We don't want to get into the biochemistry of it very much. But the challenge is this: if you look at how pain actually develops in the body, there are certain receptors that opioids certainly hit. But for every one that they hit that has to do with pain, they're hitting basically the abuse, the addiction type of receptors 5 times more. So if you blast people with opioids, yes, a lot of times they'll notice sort of immediate improvement in pain to a certain extent. But what happens is essentially where the opioids hit within your body, where they get absorbed, those immediately start to downregulate, meaning that your body needs more and more and more of them to be effective. And the problem is, as I mentioned, because they can actually alter the way your body interprets pain overall, very, very quickly, a lot of people get basically no improvement at all whatsoever in terms of pain medications, where the opioids don't work anymore for pain, but it does satisfy other types of dependency centers within the brain. So chemically, the way they work, they're not very effective for pain. Now, that's the opioid piece. If you step aside and compare that to the pathways that are hit when you use Tylenol or Motrin, for example, those pathways are much more reliable, much more consistent, all pain focused. So that's why they tend to be much, much more effective for pain. So I shouldn't say that opioids don't do anything for pain. Initially, if you have a really sore ankle and I give you a bunch of fentanyl, you will feel better for a while. But what happens is very, very quickly your body gets sort of immune to that response. And if I started with something else, one thing people actually don't talk about very much, and I'm sure you're familiar with it, Amy, is a thing called IV Tylenol. IV Tylenol is vastly, vastly more effective than most narcotics for acute pain. Now, it's 1,000 times more expensive than oral Tylenol, so people don't like to use it. But for example, when I did a lot of trauma work with hip fracture patients, we always, in fact, work with the EMS, the ambulance folks, to say, carry IV Tylenol. Don't give people morphine, because even a single dose of morphine was so damaging to the older population, they would be completely wigged out when they time they hit the emergency room. But you can manage people completely with a broken hip just on IV Tylenol alone, because it works so much more effectively for pain.
Well, and I think to add to your question too is we don't know a lot about pain. There's a lot of neurological stuff that we just, as smart as we are, as technologically advanced as we are, the treatment of pain is very complicated. And, there's different kinds of pain. There's bone pain, there's nerve pain, and And so until the medical community and researchers really figure out what kind of pain are we treating, what pathways exist, how do we treat those pathways? I mean, I'd like to see them in my lifetime. I don't know, might not happen, but treating pain itself is extraordinarily complicated, and we just don't know.
It's interesting, a small side with this, it's a great example of this. So if you do a knee replacement, for example, a knee replacement generally is a horribly painful operation. I mean, really could not be done to people reasonably without something. But what's weird is if you, and I've done this, you bring people in, you replace their knee, and then afterwards you start giving them big doses of morphine or something else, or we used to use Dilaudid and all those Demerol, those nasty things. What would happen is by the time you get 3 or 4 days into it, the pain would be sort of well managed, but they're still in lots and lots of pain by day 3 or 4. And then by the time they go home, you have to send them home on big doses of Percocet and everything else. And so they're on pain medication for the next 2 or 3 or 4 weeks. What's interesting is if you use, like this guy in Arkansas is doing, you block that pain completely at the source with some type of local anesthetic, like the dentist puts in your teeth, like lidocaine, something like actually a more powerful version of that. And you block them completely for the first 24 to 72 hours. Afterwards, at 3 days and 5 days and 10 days and 14 days, they have almost no pain from the knee replacement. What's happened is our use of the opioids has basically turned on somehow, like you said, we don't really know for sure what happens. We turn on something inside them that now has vastly more pain than they would have had otherwise if we simply could have stopped it in that first 48 hours.
Okay, one more question.
Sure.
I'm completely impressed that you as an orthopedic surgeon got what you got somewhere. Somebody taught you this, that you could tell us. Why aren't other doctors, I mean, how did you get that? Did somebody just come to you, or, I mean, what got you started on this path?
Well, I had a couple of advantages. So I was in practice for about 15 years, and I actually retired to do consulting work. And so most of the last 10 years I've done a lot of consulting on quality improvement work. And it's interesting, in that role, I was actually able to spend a lot more time reading in the medical literature to understand kind of what the real science is around some of these things. And so I had sort of the time and the ability to do that because my work depended on it. The vast majority of docs in practice, again, sounds sad, they don't have much time to read, they're not very current, or if they do read, it's very specific, like in orthopedics. I don't read about pain control or anything else like that. I read specifically about what's the best suture to use to close a rotator cuff surgery in a shoulder. So that's what they focus on right now. So that's what, basically for me, it was a matter of saying, okay, let's find out what best practices look like because I spent a lot of time researching it. Now, the other sad thing is, I'm sure if you guys know who Atul Gawande is. Atul Gawande is a Harvard neurosurgeon. We've written a bunch of stuff about quality in healthcare, but he makes the point, which is very well supported by the research, that if a new thing in science comes up, a new thing in medicine is discovered today, comes out in the medical literature and it says, wow, you should not use drug A, you should definitely use drug B instead for whatever, right? On average, it takes 17 years, 17 years before this new piece of knowledge that occurs in the medical literature to become common practice among physicians in America. So things like opioids, for example, is that there is a lot of research coming out all the time, but on that timeline, we won't have much of an impact on the doctors knowing how to use it till about 2032 or something like that. So it's a long way in the future.
Okay, thank you.
I'm sorry. Okay, all right. I don't want to take long. I'll be around after.
I just wanted to make a couple of comments about, number one.
I'll give you the.
I really mean it.
They can hear you on the.
I know it's being recorded. Okay. Number one is physicians in the state of Colorado do not have to take CME. So that is something that won't happen. Okay. And the other issue that I want to bring forth that came about this year is we passed a number of bills in regards to the prescription drug monitoring program. And Dr. Valak, the dean of the School of Pharmacy, was very helpful in the process of doctors' ability now to be able, doctors, pharmacists, veterinarians, dentists, anyone can check that PDMP for a specific patient. And before this bill was passed, I believe, and correct me if I'm wrong, you could only check it if that patient was in the office talking to you at the office appointment. So you couldn't check PDMP. Maybe you could when they came in to get their prescription filled. Now, if you feel like you're going through your records, for the next day or in the morning for your patients, you can check that PDMP for that particular patient and see if maybe they've been on opioids for quite a long time or what the dose was. And so I think this is a step forward. This is a new bill that was just passed into law. And there are a number of other ones that are there in a continuum to help this. And so I'm hoping that you'll find this helpful in the future to try to, you know, decrease the opioid use and help you all out and help the patients out.
Well, let me follow up on that briefly, so I do one more minute. So real briefly, PDMP. Do you guys know what the PDMP is? Prescription Drug Monitoring Program. Essentially, it's a state database. As you might imagine, it's basically the pharmacist entered the information. That's why it's accurate, because if the doc did it, it would be ridiculous. Basically, it's a state database that monitors, so any prescription for opioids or benzodiazepines, right? Pain control, okay. Okay, thank you. In Colorado, basically gets recorded within this state drug database. Now, the docs, actually, any prescriber in Colorado, so doctors, nurse practitioners, pharmacists, PAs, veterinarians, and dentists can all check it. Now, do you know what the current check rate is among physicians in Colorado using the PDMP? So what the number is? It's a little more than 15% currently. Yeah, 3.
Up by 3%.
Well, that's
We're like at 18 now.
It's 18. Oh, there we go. Yeah, we're 18. So we're missing. I'm missing free throws. Missing out of 4 or 5 out of free throws. Now, so a couple of challenges with PDMP. Have you ever checked the PDMP? Anybody here checked it? This is not just Colorado, average nationwide. It's 5 to 7 minutes per patient one time. Incredibly slow, very kludgy system, very difficult. Now, that's problem number 1. Problem number 2 is, have you ever seen a PDMP report? It is line upon line upon line upon line upon line upon line. I mean, literally sometimes like 15 pages of simply, you know, Mary Smith got Vicodin from Dr. Jones at this pharmacy at this date. And they just list and list and list and list and list. Now, the problem is if you have patients that are, you know, have significant problems, they'll have vast, vast numbers of different prescriptions they've gotten over the years, some of which are appropriate, some of which are not. Okay, sometimes they're getting Vicodin, sometimes Percocet, sometimes something else. There's no real standardization of what the dosages are or anything else. So again, back to the education issue, the vast majority of docs, one, they like to check the PDMP because it takes too long, but once they see the reports, they have no idea what to do with the information. So it's a real problem. But if, in fact, your point is, in my mind, if you do nothing else, the doctor should at least be checking the PDMP because it gives you some idea of where the patients are starting as a baseline. And some ways to make that easier, which I can talk about with you later. But it's yeah, anyways, it's cumbersome. It's a problem right now, and that's not just Colorado. That's across the country. All the systems are very kludgy. So they're talking now about how to do it, but automatically checks on patients and gets put into an EHR and alerts on a flag and that kind of stuff, which needs to happen. But that's still a ways in the future.
Actually, that's actually a really good takeaway.
I'm going to talk about that.
So that was awesome. It doesn't get any better than that invitation. It's so nice to see you. Good morning, Representative Janal. Good morning. I'm Kate Horle. I'm the Chief Operating Officer at CORHIO. We're very excited to talk a little bit about the PDMP this morning and some other things, particularly solving the awful kludginess of that problem, because it's terrible and that's why people don't use it. Because who's got 7 minutes to wait around for something that might not even give you any information, right? Oh, you're so good. Thank you. Just a little bit about myself. I've been the COO at CORHIO since last October. I've been with the organization about 3 years and a couple of months. My background is in public policy, and it's been very peripatetic. So I've done healthcare, water, transportation, affordable housing, all those good things. So when I came to CORHIO, I came with this public policy background and not a technology background. So while I can talk at a very high level about technology, if you want to start asking me about how to build an interface, I can point you in the right direction, but I'm not going to give you the wrong information. So quickly, there are 2 health information exchanges in Colorado. These are organizations whose sole and certain purpose is to move data between hospitals and doctors, between hospitals and providers, and to enable providers to understand the data that they have on their own patients. So we do that work in a variety of ways. We help providers understand their diabetic cohort, and when folks are receiving care outside of that doctor's understanding, we send an piece of information to that doctor saying, hey, Kate Horle got a finger stick at the 9 Health Fair, and she was out of range. So you might want to give her a call. We do that kind of work. We also do the work that says, hey, Kate Horle had a baby 2 weeks ago, and you need to get her in and her baby for a well child check. At the same time, we also move that patient data because patients don't just go to one hospital and one doctor. Patients, particularly those with comorbidities, go to up to 7 to 9 doctors on a regular basis. And we store that data and make it available by patient name so that providers can have access to a patient's complete care record and understand their patients better before they sit down to meet with them. So there's 2 of these entities in Colorado. CORHIO is based here in Denver, and we cover the Front Range, Eastern Plains, and down into the southwestern part of the state. Our friends at Quality Health Network are based in Grand Junction, and they cover the 13 counties on that in that western corner up through Routt County. Next slide, please. So a little bit about CORHIO. Today we have 61 hospitals connected across our service area. We have more than 10,000 total users. This includes hospital users as well as non-hospital users. And we have more than 4 million patients in the community record. And actually, just so you're aware, we just did a deduplicated study of our patient database, and we have 4.8 million Coloradans in our patient record, and then a whole bunch of other non-Coloradans. CORHIO's patient record includes folks from almost every county in the country, although suspiciously not from northern Maine, which is very interesting.
Nobody
Next slide,
lives there.
please. Right. Well, or they don't leave, which I find fascinating. Having spent a fair bit of time in that part of the world, I can imagine that they don't leave. So one of the things that we just did and that we do on a regular basis is talk to our customers about what data they want. What's the information that really matters to them when it comes to providing care to their patients? Recognizing that doctor schedules, Dr. May did a great job of talking about how limited their opportunity is to read and research and understand those things. What information do they really need to understand their patients? And so I know this is really itty bitty, so I'm going to talk a little bit about what's on here, but at the top of the list is medications prescribed. Now you would think that would be really easy to get, but it's incredibly expensive to pull in. And we're a not-for-profit organization, so we're trying to find new ways to create that data. The second thing on the list is primary care data. So the specialists who are connected to CORHIO really want to know all that primary care information, and the primary care docs want a complete record of that primary care information. And then third on the list is medications filled. And this is the place where hospitals really struggle. When someone shows up in an emergency department and they're not cognizant of where they are or what's happening, they certainly don't have a list of medications on them. And to have access to know what prescriptions have been filled is really important to those ED docs. Same for our EMS partners. When they show up at a scene and they have someone who's unconscious or who isn't really being able to focus on that individual across from them, it's hard to know exactly what prescriptions they are on. And if a emergency medical service personnel person, an EMT, says, "Were you at the hospital yesterday?" and that person says, "Yes," and they say, "Did you get a prescription?" and they say, "Yes." "Did you fill it?" "Maybe." "Did you take it?" "I don't know." That information is really valuable. If the prescription's been filled, it's much more likely to have been taken, obviously. And EMTs need to know that, because sometimes the person in front of them doesn't need to be transported. They need to take the prescription that were prescribed yesterday at the hospital. So these are the 2 key pieces that we're trying to get for our customers today. Next slide, please. So the Prescription Drug Monitoring Program. This is a database of prescribed and controlled substances, and it's critical in understanding drug use in Colorado. Opioids, narcotics, and other kinds of drugs that live in the Schedule 2 through 5 database. This is not about antibiotics, right, or heart condition medications. This is about that small percentage of controlled substances that is running wild and rampant in the state of Colorado. Colorado is the 3rd fastest growing abuser of opioid prescription drugs, and this is a very high priority for the governor. And so as part of becoming the healthiest state in the country, we want to manage this problem, and CORHIO is working very closely to make that happen. So access to this medication, as well as the other kinds of medication, is really critical to our partners. And so about 3 years ago, we began working with the Department of Regulatory Agencies who host the PDMP to understand how we could make access to the PDMP much better. So there was a piece of legislation that passed 3 years ago which enabled not just prescribers to look at the PDMP, but 3 delegates to look at the PDMP. That was huge. Those of you who understand how a workflow is inside a physician's office, it's not the doctor or the nurse practitioner who's looking at the PDMP or who has time for that. It's their medical staff that has time for that. And so we want to make sure that those folks are looking at that document and have access to that information. So that was a really critical piece. The second piece, and that also required them to register for the PDMP. Doesn't require them to use it, but they have to at least register for it. The second piece that really matters is going in to look at that and returning some information in a time frame that is reasonable. 5 to 7 minutes, or even 3 to 5 minutes, which is what we tested it at. Not reasonable. It needs to be click present. So we've spent a little bit of time trying to understand what that might look like. Next slide, please. So what we ended up doing is working with the Colorado Department of Public Health and Environment and the Centers for Disease Control on a grant project to integrate the PDMP directly into our provider portal. So today, that provider portal provides thousands of practitioners and their staff access to the longitudinal patient record of Coloradans and others who visit our hospitals and primary care practices across the state. What would happen is, and that's part of their regular workflow, particularly for new patients. They look at that information, or when they receive one of those alerts. Kate Horle had a baby. Kate Horle was in the emergency department. Kate Horle had a finger stick at the 9 Health Fair. They go back into that longitudinal record to see the labs and other information, admit information, discharge information on that individual. So what they will do is they will go into that longitudinal record, query the PDMP from our longitudinal record. That information will appear in a medications tab right alongside the other information that we have for that patient. So they can see Kate Horle was admitted to University Hospital. Kate Horle received a prescription from University Hospital. Kate Horle had a prescription filled at University Hospital. It becomes much more logical because you can connect that prescription filling to an actual event. So we're really excited about this project. It's been a little bit torturous, I won't lie to you, because the CDC originally denied our grant in Colorado because we were too technologically savvy, we were too far ahead of the curve. And then they came back to us and said, we take it back, we really want you to do that. Well, in that 4-month window, DORA decided to reprocure the PDMP and they went out to bid. So there was this moment of, oh God, we don't know who the vendor will be, right? That's really important. For us to be able to connect to the PDMP, we have to actually know who we're connecting to. So they went through a reprocurement process, which then failed. And so then they had to go through the reprocurement process again. So we're now 18 months after having received the grant and finally getting started. We're super excited about it. So on the western slope, St. Mary's Regional Medical Center will be the participating hospital for this pilot. And in Colorado, I was hoping I could tell you, but we still haven't signed the commitment letter from our big partner hospital that will be joining us. It's actually going to be about 6 hospitals in the metro area in the emergency department that will be participating in this pilot with us. So once the grant is fully executed through our friends at CDPHE, this fall, we will begin that connectivity process. We will have, we hope, about 9 full months of testing to see how often it's utilized, how helpful it is to doctors and their staff. We will be surveying staff before and after and during this process to see if they use it, if they like it, if they're getting results returned in a much more timely fashion, all that good stuff. I think there's a next slide. Is that the last one? Oh, okay. So I wanted to talk a little bit about what it'll look like. This is the medications tab inside of CORHIO's longitudinal record. So when you go into the longitudinal record and you query it, what you will normally see is this patient summary tab is open. And what that is again, a record of the patient's admissions, discharge, and transfer information from hospitals around the metro area, as well as whatever other information might be in there that your particular practice is interested in. There's a tab you can see that says medications. So when you are doing this work with the PDMP, the provider will click on this tab, and then there will actually be a button. I think the button will be right here that says Query PDMP. And they'll merely just click that button, and the PDMP will show it'll be where this medication alerts piece is, it'll be right here. It just comes right up in the system and says, here is the record of what we have on that patient. The other thing that's really great about the PDMP, which is something CORHIO and QHN don't have access to, is they have also known as names. So folks who have received drugs under Kate Horle, so I'm a great example here because I'm Catherine with a C and Kate with a K. So Catherine Horle might have gotten prescriptions, Kate Horle might have gotten prescriptions. To make matters much more complicated, my husband and I don't have the same last name. So Catherine Davis, who might actually be me, could have received a prescription because my insurance company is under my husband's name. So periodically they get very confused about whether I'm still married to him or what our relationship is, and then they start sending stuff for Catherine Davis. So I'm a great example of Kate Horle, Catherine Davis will all show up here with every prescription that I've ever received that fits in that Schedule 2 through 5 place. Next slide, please. Oh, okay. We go back to that. I thought maybe we had one more slide. So the other thing that's really nice for the provider is that we solved this giant list problem because they can just see the last 5 or the last 10 or the last 15. They won't have to see the 500,000 items that Dr. May so aptly described. Now, we haven't solved that magical problem on the longitudinal record side, but we will be able to do it in the prescriptions tab, in the medications tab, we think. So we're very excited about that. Because you're absolutely right. What doctors want to know primarily is this person doctor shopping? Did they go to university and get a prescription for Vicodin, and then to Swedish and get a prescription for Vicodin, and then Aurora Medical Center and get a prescription for Vicodin, thus hitting 3 different hospital systems, right? They've been to university, they've been to Centura, they've been to Health One, and they got them all, 60 count, in the same day. This will show all 3 of those immediately. It's a great opportunity for doctors to have that information right away. So I'm going to stop because it's my last slide and I've talked really quickly. And I want to answer questions. Yes, ma'am.
And the bill that I was talking about also provides the opportunity now that it's talking with 40 other states. So you're connected to 40 other states. So if that person goes to these 3 hospitals here in Colorado, and then they decide they're going up to Wyoming to go doctor shopping or Kansas, you can also pick that up too.
Right, because it's all the same vendor. So there's a benefit to that and a downside. The benefit is the vendor is APRIS, and they do the PDMP in 40 other states, but it also means they have a corner on the market, and they're really, really, really expensive. So our big concern is once this grant is over, how much is it actually going to cost me to keep it up? And the APRIS has a lot of rules about their connectivity and how you have to do it their way. And because they have a monopoly, it's a little tricky. So it is wonderful that you will have all that data. The challenge for us is making sure that we make that data affordable to our providers once this grant is over. Because obviously for our hospitals, we'll be able to do this for free under this project. In the long run, we're not exactly sure how we're going to maintain that. So I just want to, there's an up and a not so wonderful there. Other questions? Okay, great. That was fast.
All right. So if anybody has questions for the other speakers or questions as a whole, we have some time. Otherwise, I can release you early. I think we're about 30 minutes ahead. So any questions that you guys can think of that you want answered? No? Okay. All right. Well, thank you so much for joining us. I want to thank our speakers very much. I want to thank Representatives Janal and Ransom for coming. We appreciate your support and your interest. So thanks, everybody. And The recording will be available, and I think the slides will. I just want to check with all the speakers to make sure that the slides are shareable. So, okay. All right. Thank you.
That is exciting for real.
It's super exciting. We are chomping at the bit.
Yeah.
Can't wait.
Oh, my gosh.
And it's even more exciting that we thought we were only going to be testing in one hospital, and now that we're